All right, so for some of you guys, might be your first time to sort of see unknowns. So basically, the way we do this is we just ask who wants to basically go.
Big share.
Yeah, okay, good.
Okay.
Yeah, we got 5 folks. So basically, someone start off and tell us what you see, and then we'll just kind of work through it.
This looks like a shaved biopsy,
Good.
and it looks like it's inflammatory. There's a lot of purple cells in there.
Good. Can you tell much about what part of the body that you're on?
It looks like it would be a site that doesn't have a lot of hair follicles and isn't very thick.
Good, good, excellent. So, at low power, that's kind of what you're saying. It's just kind of general information. Sometimes you can make a specific diagnosis of low power, but sometimes you're just kind of getting a general sort of lay of the land. So yeah, we think it's inflammatory. We don't really think it's neoplastic. And you say there are some purple cells. There's some dark cells at the periphery here. But what about these cells?
Yeah, there's some lighter ones mixed in.
Good. And it seems to me like these lighter ones predominate more than these darker ones at the periphery. So that's kind of a clue. So if it's an inflammatory process, meaning that it's comprised of inflammatory cells, and the cells at low power look pale to you, what kind of cells do you think they most likely are going to be? You don't know, that's perfectly fine.
Maybe?
Well, generally, if you see
histiocytes.
Oh, histiocytes, yes.
Good, excellent. And if it's histiocytes that predominate, like here, they're the majority of the cells here. What can you say about what do we call that type of inflammation when histiocytes predominate in an infiltrate?
Granulomatous.
Good, excellent, good. So we got a shave biopsy. We kind of wish we might have had a punch biopsy, but we don't have that. But we got a shave biopsy, histiocytes predominate, granulomatous inflammation. Okay, good. Now there's several patterns of granulomatous inflammation. And this you may not know yet, but do you want to venture out and suggest some possible patterns of granulomatous inflammation that we see histologically?
Sorry, Marissa, if you don't mind, I can suggest some too.
Yeah, go ahead.
There's sarcoidal or naked.
Sarcoidal, good. That's excellent. So there you see like small, round epithelioid granulomas, usually with limited lymphocytes there. So that's sarcoidal granulomatous.
There's like suppurative granulomatous.
Granulomatous, excellent. Where do we usually see suppurative granulomatous dermatitis?
You mean with which diseases or what location in the skin?
Which disease?
Usually like bacterial or fungal, infectious.
Yeah, infectious diseases or like rupture of like folliculitis, things like that. So that's good. Yeah, good. Excellent. So those are 2 patterns. What are a couple of others?
I think tuberculoid is one.
Good. Tuberculoid granulomatous inflammation, where you see kind of central caseation degeneration. There's a couple of others.
Foreign body.
Yeah, foreign body, right? Yeah, that's right. Foreign body. That's related to again a kind of ruptured cyst, things of that nature. There's one last one. Palisaded, where we see like granuloma annulare, necrotitis lipoidica, rheumatoid nodule, and those diseases. Good. So let's go to higher magnification. And what do we see here? In addition to the histiocytes, what are these cells?
Neutrophils.
Good. So neutrophils and histiocytes. So it's a suppurative granulomatous process, right? So what are we going to do? We're going to kind of go on a bug hunt. We're going to see if there's a possibility that this is an infection. Good. So this could very well be an infectious disease. And I think you had a special stain with this one, right? If you look carefully, you might even see something that looks like it might be an organism right here, maybe some others in these areas over here. And then I think there was a special stain that was submitted. And if you looked carefully in this area, like here, look at that. You see that organism right there? Any idea what that is?
It's like it's not like a fail hypomycosis or something
Well,
like
it
that.
wasn't a pheohypomycosis. It actually, in this case, was blastomycosis. So if you're looking at like chromoblastomycosis or those kind of conditions, basically there you get the organisms are pigmented and you can see them with H&E. So we couldn't really see here with H&E. We had to get the PAS stain, and it's positive here, and it's got this. You can kind of see that's got kind of a. It's as high a magnification as we can get here, but it's got this little sort of darker outer sort of shell, if you will. That's the cell wall, and then centrally it's got the cytoplasm here. So that's the actual blastomycosis spore, if you will, in tissue. And here, if you look carefully, you see it's actually budding. And blastomycosis, remember, it's the one that gives you broad-based budding yeast, especially when you see that in culture. Here's another cluster of them right here. So this was a person that had cutaneous blastomycosis. So you will see infectious diseases on the board examination. So it's early in the game here for you guys, but here's another one right there. So you definitely are going to see infections because they first of all they can't argue. No one can say, well, it's something else. It's pathognomonic when the organisms are present in tissue, and they want you to be able to recognize these organisms. They want you to be able to know the various patterns. So like in cocci, for example, you know, the barrel-shaped arthrospores that you see in the mariner's wheel type of things that you see when you get them in culture and those kind of things. So make sure you know those deep fungal infections. Okay, good. Excellent. That's the way that we do it here. Simple kind of stuff.
I can try this one.
Okay, great. We
It
like
looks
this
like,
better, don't we?
yeah, it looks like it's a punch biopsy. It looks like
Yes.
there's inflammatory infiltrate deeper in the dermis. It almost has this like purplish color from the scanning.
Good.
And I guess if you zoom in more, I noticed that there was these they're like the pale epithelioid cells. They look like histiocytes that were surrounding. It's they almost look like they were palisading around this mucinous area.
Okay, so very good. Now you said they almost look like they are palisading. Is it possible that they just absolutely positively are palisading around these infectious
Yeah,
diseases? Yeah, so it's
so
definite.
I thought,
Absolutely slam dunk, LeBron James. The ball goes right into the net and it falls off the rim. So this is a perfect, beautiful example of palisaded granulomatous dermatitis. Excellent. Very good.
so I thought this was this could be palisaded granuloma annulare.
Yeah. You said palisaded granuloma annulare. Granuloma annulare is one of the diseases that gives you palisaded granulomatous dermatitis histologically. So you don't really have to say palisaded GA. I mean, it sort of always is GA. Now there are a lot of different types of granuloma annulare clinically. Do you know some of the subtypes of GA that we see clinically?
Yeah, I mean you can get like I think perforating,
Good. Yes.
you can get disseminated granuloma annulare, and then yeah, I'm Pat is more like interstitial granuloma
The
annulare.
interstitial GA type. Good. And you see that, and actually, if you see those patients clinically, they usually don't give you the nice annular classic sort of pattern that we see with most patients come in with typical GA. They usually kind of give you more kind of a pink macular appearance, and clinically that's often confused by dermatologists. They think it's mycosis fungoides, or they think it's Morpheus, something like that, and they biopsy it, and we give them back a diagnosis of interstitial GA, and they don't believe you. So yeah, what about this pattern? We're looking right here. What type of clinical would this be possibly? If we just had this only.
I thought that was also palisading, so I'm not sure.
It's still GA, but this would be maybe subcutaneous GA.
Oh,
So
okay,
sometimes you'll
that's
see a
good.
kid that comes in with a kind of a deep nodule, maybe around the ankle or something like that, and you're not sure what it is, and you biopsy it, and lo and behold, it comes back as subcutaneous granulomatosis. So yeah, that's just another clinical form. So that's good. You got most of the clinical forms. It's excellent. So yeah, now so you said palisaded granulomatous dermatitis, and you're correct. This is granulomatous. What are the two other major palisaded granulomatous dermatitis that are in the differential diagnosis of GA? There's three main ones. There's more than three when you get to be a third year that you need to know for the boards, but there's three main ones that we think about when we think of the palisaded granulomatous dermatitis histologically.
You think about like a neutrophilic one?
Well, there is a type of interstitial granulomatous dermatitis with neutrophils associated with connective tissue disease. That's not one of the three major ones, but it is definitely one that you sort of ultimately need to know. But the three main ones that we think about.
Or like not like rheumatoid. Is that
Rheumatoid nodule, and what's the last one?
this one. Like yeah, I don't know the last one.
You probably do, but you're just not thinking about it. Who knows the last one?
Is it lupus miliaris?
No, that's actually more of a tuberculoid granulomatous process, but Necrotizing lipoidica, NLD. So those are the three main ones we think about. We think of the three classic palisaded granulomatous dermatitis histologically. And how do you tell those apart? Okay, so what's the main way that we tell those apart? Now, let's say we just have like this field alone. We don't have the biopsy to look at the so-called layer cake of granulomatous inflammation and whatnot over the diffuse pattern. Let's say we have only this. What's in the center of the palisades of the three main palisaded granulomatous dermatitis?
Is it like mucin and fibrin?
Mucin in which disease?
Granuloma annulare.
Good, and that we see that here, right? This sort of bluish gray material that's sitting in the center of this palisade right here. So this is mucin. So that's what you see in the center of the palisade in GA. What about a rheumatoid nodule? You said it a second ago.
Oh, a fibrin.
Fibrin, good. And what about an NLD?
Collagen.
Yeah.
Yes, degenerated collagen. Good. So those are the three things. Now, when we say palisade, you guys know what a palisade actually is? If you go back and watch some of the old Western movies from years ago, or Last of the Mohicans, something like that, and they have those forts that they have those logs that they make those sharp points and they stick those around, and the people are sitting inside the fort there, and they're protected from the enemies on the outside. That's what's a palisade. It refers to those little, it's like those sticks are put into the ground to make kind of like a fort, something that protects you, if you will. So the histiocytes are kind of like the little poles out here, and the people are like the material that's sitting inside the fort here. So they're protected, if you will. That's a way to think about it. Another way to think about it, Dr. Al Kopp, who was our attending of mine years ago, used to call these the thesaurus, like thesaurus, thesaurus moses, thesaurus moses. And a thesaurus is a treasure chest. Basically, that's what the word actually means, like a treasure chest, if you will. So if you have a thesaurus, you're looking up words that are the treasures. So you think about the material that's in the center of all these histiocytes is the material that's the treasure inside there. So that's basically, you think about fibrin, degenerated collagen, mucin, those you're looking for that's what's in the center of these various palisades here. So you can make the diagnosis with specificity. And sometimes it's, if you get a deep GA, that's really, you need to look to see what's in the center of that palisade, because the rheumatoid nodule can look very much like deep GA, but it has mucin versus fibrin. So that's palisaded granulous dermatitis in a nutshell. You'll hear a lot more about that when you get to the board examination also. Okay, some really good inflammatory things today. Who wants to give this one a go? The good news about these conferences is that you cannot be incorrect. If I say, what do you see? That's what you see. It's like if you go to a restaurant and somebody says, well, what does it taste like to you? Well, that's what it tastes like. So you're not wrong. It's your experience. So you can't be wrong. If you have a morbid fear of being wrong, you don't have to worry about it in this conference, because that's not the goal. It's basically just to learn to describe and see things and observe, because on the exam, they're going to toss these things to you, and you want to be confident when you see these. You don't want to have your heart rate go up 1 millisecond. You want it to go down in number. So the old saying is, bleed in practice and sweat in battle. So that's what we're going to learn to do here. So who wants to do this one?
Okay, I can try here.
Good.
Okay, so sorry, there's some echo going on. Here we go. Okay, so I'll just go ahead and try. So we have to be what looks like superficial and deep perivascular infiltrate with maybe some periadnexal infiltrate as well.
All right, low
This is a
power
little
on a
more
scale of
purple.
1 to 10. How much information do we see here on a scale of 1 to 10?
Like little, I guess.
Yeah,
Let's
one.
say a 2.
One. It's very minimal. Yeah, you're right. And I wouldn't say it's superficial and deep. I'd say it's just barely superficial perivascular dermatitis. Really not a whole lot going on. So, and you can see it's a punch biopsy taken from sun-damaged skin. A lot of bluish gray solar elastotic material here. Okay. So we don't see a whole lot. So when we see something that's in the differential diagnosis of almost a nothing diagnosis, that's kind of good news and bad news. I mean, the good news is a low power, you don't really see a whole lot. The bad news is that there's a long differential for things that give you minimal inflammation at low power. So what are some things that and if there is inflammation, it's mostly lymphocytes. We'll go to higher magnification, see if we see anything more here. Now we do see some more. What about in this area? Now what do you see?
I mean, I see lymphocytes. There's some epidermal changes going on too.
Yes,
Looks
there
like.
are some epidermal changes. What kind of epidermal changes are you seeing here?
Well, it definitely doesn't look uniform. There's some.
What are these little things that the arrow is pointing to?
I mean, are they? It looks like vacuolar changes.
Yeah.
I mean,
Good. There's vacuolar interface dermatitis here. Holes. So the answer to a lot of these questions is really elementary. I mean, these are not like rocket science. You look, you see holes. What causes holes in the base of the epidermis? And then what are these structures?
those dyskeratotic keratinocytes.
Good, excellent. Dyskeratotic necrotic keratinocytes. Excellent, very, very good. So we've got a sparse superficial perivascular dermatitis. We've got vacuolar alteration of the dermatomal junction. We've got dyskeratotic keratinocytes. What about the cornified layer?
Some parakeratosis.
Good. What do you think this thing would look like clinically?
Have a scale on it.
Good. Excellent. It's going to be scaly. probably a little bit red. It's got some dilated blood vessels. It's going to be scaly. It's on sun-damaged skin. So what's the differential diagnosis of conditions that give you a superficial perivascular dermatitis with vacuolar alteration and diskeratitic keratinocytes? What do you think about?
Hmm. I don't really know.
Okay. Anybody want to help him out that might think of some thoughts?
I guess like you can get like pleva, PLC.
You could get pityriasis lichenoides. You
Um,
could. That's in the differential. Usually that's going to give you more inflammation than we see here. What else could do it?
Like
What's
drug
the most-
reactions.
Drug. Very good. Drug reaction. Probably the most common. People are taking medications, all the time. And this person is an older person, right? Because look at all this sun damage. So somebody that's got this much sun damage, probably an older individual, chances are probably pretty good that they're taking a medication. And so they've got to, when you see this pattern, interface dermatitis, vacuolar alteration, sparse infiltrative lymphocytes, yeah, good. Drug eruption would be something you'd think about. What else? One or two other things maybe that you might throw in the differential here. I don't think it is these other things, by the way, but just name one or two other items that might give you an interface dermatitis with vacuolar alteration with diskeratotic keratinocytes. Usually more inflammation than we see here.
EM.
Good. Erythema multiforme, possible. Yeah, absolutely. Give you a little bit denser infiltrate usually, but yeah, that's definitely in the differential. Then there's one other thing.
Lupus.
Good, lupus. Lupus. So, and again, here, there are things that don't favor those other entities. So this turned out to be a photo-exacerbated drug eruption in this case. That's what the diagnosis is. But those are some other things that you should think about, that should run through your mind when somebody calls you at 3 a.m. and says, hey, I got a biopsy here that shows a vacuolar interface dermatitis with some diskeratotic keratinocytes. What should I think about? So you throw out those things. And they say, oh yeah, he's taking, hydrochlorothiazide. Thank you. It's a drug eruption. So that's kind of how these things work. Okay, good. Very good. All right, let's go on to the next one. Different pattern here, but an important pattern. So the fun part of this is just you're seeing these patterns of histologic inflammatory diseases, and then it's sort of like a Christmas tree. You start putting the ornaments on the tree, the various things that can cause the pattern. So you got to be able to recognize the pattern. Once you do that, then you start thinking, what can cause the pattern? That's how then you come up with a differential diagnosis, and then you sort of say, well, is there anything else that can make it more specific? So general pattern, maybe 10 things, 20 things, whatever can cause that. Then you start looking at more specific entity things, like whether there's additional information that's going on in the dermis or the epidermis, whatever. And then you hone the diagnosis, and you finally come up with something specific that correlates with the clinical. So what pattern are we looking at here?
There's some perivascular inflammation.
Good.
Um,
Perivascular
and-
dermatitis, and it's mostly perivascular at low power, right? There's not a whole lot of
Mhm.
stuff going on between these little nodular aggregations. Good.
Yeah.
And what kind of and where is that? You said it's perivascular. There's obviously
Yeah.
a deep perivascular plexus. Is this superficial only or superficial and deep?
I think it's superficial and deep because it's
You're
kind
right.
of going
Good.
around the
Superficial and
adipose.
deep. Good. Absolutely. Good. Excellent. Correct. What kind of cells are we looking at here at low power?
They look mostly like lymphocytes.
Yes. If they look dark and black at low power, they're going to be lymphocytes. Now, we may go to higher magnification. There may be some EOs. There may be, some plasma cells, something like that. But at least at low power, we're going to say this is a superficial and deep lymphocytic infiltrate. Now, that's good news, because that really hones the differential diagnosis down into about 8 or 9 different things right there. So you can throw out 1,000 things. So there's only about 8 to 9 things that can give you a superficial and deep infiltrate with lymphocytes at low power. So what do you think about here? Before we go to high magnification, what are some of the things that you're going to throw into the differential diagnosis of that pattern?
I think of lupus.
Good. There's a mnemonic. Now, I love mnemonics. To me, that's the only way to remember things long term is you got to have something in your mind that you can picture and you know, or something like we talk about Bengal or England for the painful tumors. Well, this pattern also has a mnemonic. So do you know what the mnemonic is for this?
I don't know that mnemonic.
Who knows what it is?
The L's.
The L's. Good. And how many L's are there?
7.
7.
Yeah, 7 or 8. Yeah, right. So what are they? You said 1, lupus. Which type of lupus, by the way, tends to give you the L, this pattern?
Discoid.
Well, discoid usually gives you some interface change also, you know, with the thinning of the basal epidermis, the thickening of the basal membrane zone, follicular plugging, all that kind of stuff. So usually not discoid. The tumid form of lupus gives you a lymphocytic infiltrate primarily. And if you look in the dermis with that, you'll see mucin. So that's how you really make that diagnosis more specific. So if you see lymphocytic infiltrate with mucin, think of tumid form of lupus. So what are some of the other L's that we think about?
Like polymorphous light eruption.
Polymorphous light eruption. Good. That's the light part. And what do you see there that helps you make the diagnosis more specific? Which we don't see.
Papillodermal edema.
Excellent. Papillodermal edema. Very, very good. What's another one?
Leprosy.
Leprosy can sometimes do it. Yes. Yes. Especially kind of indeterminate Hansen's disease can sometimes give you a lymphocytic infiltrate. Yeah, that can do it.
Lyme disease.
Lyme. Good. And when you think of Lyme, throw in there the other gyrate erythemas. So when we think of Lyme, you mean like erythema chronica migrans, erythema annulare centrifugum, that can be associated with individuals that have got underlying cancers and things of that nature. So that kind of all goes into that category. Lyme will often give you lymphocytes and plasma cells. And when you think about Lyme, you should also think about so-called Starry syndrome, which is basically Lyme disease in the South, where it's too hot for the Ixodes, Gamini ticks and whatnot. It's probably caused by another tick bite. We just haven't identified the causative organism in that yet, but it gives you similar clinical and features as Lyme disease. There's a couple of others.
Leukemia.
Yes.
Chronic.
What type of leukemia?
Chronic.
Chronic, which type?
Leukocytic.
Yeah, chronic lymphocytic leukemia. Good. That actually, in this case, believe it or not, happens to be the diagnosis here. So this was somebody that had CLL and developed the, pink papular lesions on their skin. So this is the CLL of the L's here, which is kind of interesting. This patient had known CLL and popped up with these lesions. There's 1 or 2 others. I'll just go for one other.
Lymphoma.
Would you say lymphocytoma cutis? Is that what you said, Kieran?
I said lymphoma.
Yeah, some of the lymphomas can look like this also. I throw that in there too.
But pseudolymphoma too.
Yeah, pseudolymphoma, that usually is more of a nodular sort of wedge-shaped infiltrate with EO, so it's not the classic pattern of this. But the last one is so-called lymphocytic infiltrate of Yesner. Okay, that's a wastebasket diagnosis. It's probably not really one disease. Most of those patients probably really had tumid LE or polymorphous light eruption, but you'll still hear that term, lymphocytic infiltrate of Yesner. And that basically gives you the same type of histology. So notice this one doesn't have mucin. It doesn't have papillodermal edema. So, you know, you might say, well, yeah, it doesn't really, maybe it's more of a gyrate erythema or Lyme. It doesn't have any plasma cells here. It's just mostly lymphocytes. So in this case, you know, we didn't know for sure it was leukemia until we looked at the pathology rec slip, and lo and behold, the patient had CLL. So we were able to make a definitive diagnosis. But that's how you do it. Look at the pattern, come up with a differential, start seeing if there's other stuff in there that you can kind of help make more specific diagnosis, and then you look at the clinical information and correlate it and come up with a final diagnosis. Okay, this is a sort of an ugly looking slide here, unfortunately, but if we can at least find one area that might at least give you some information here. There's probably a reason that it's kind of ugly looking. But I think we can come up with a differential diagnosis here too. So what do we see here? What are you guys seeing at low power?
Shave biopsy.
Good. Shave biopsy, inflammatory or neoplastic? Or maybe you don't know.
I'm not really sure, but favor inflammatory.
Good. Favor inflammatory. Good. What pattern if it's inflammatory? We have a lousy biopsy that is shaved, which we don't like, but it may be that this was a very friable lesion. So we'll give them the benefit of the doubt. Maybe they said, I can't really do a punch here. It's not going to work very well. So they did a deep saucerization biopsy.
Mhm.
So what pattern is this if we look at it and just at low power?
Diffuse.
Diffuse. Good. Excellent. So nodular, diffuse. I mean, the whole thing is involved. Side to side, top to bottom. If we had a deep punch, it probably the whole thing would be a sea of inflammation here. And what kind of cells are we looking at here?
Like mostly lymphocytes.
Well, some may be lymphocytes, but do they look quite as jet black?
Oh,
As those-
not there. It's
They're not
interesting with something else.
They're not as dark. Okay, they're not as dark. When they look a little bit lighter, now they don't look like the histiocytes like we saw in the very first one either, right?
Yeah,
Look
it's like
different.
yeah,
Kind of looks maybe like salt and pepper if you want to
yeah.
think that way. So when you see something this, well, they're not dark enough for lymphocytes. They're not quite light enough for histiocytes. They probably then are going to be neutrophils. So it's almost kind of like by diagnosis of exclusion. So if this is a sea of neutrophils, our magnification, see, we're right. They are neutrophils here. That gives us a differential diagnosis also. And it's also not gargantuan. So what diseases cause a dense diffuse infiltrate of mostly neutrophils?
Maybe
Sweet
sweets?
syndrome,
Sweets can do it.
pyoderma,
Pyoderma gangrenosum can do it. Can't stop there. What else can do it?
Infections,
Infections. Good. Which kind of infections, by the way?
usually
Most
acute
common.
bacterial.
Yes, pyogenic infections, exactly. Staph, strep, those kind of things. Yeah, abscesses. And, we get biopsies of abscesses all the time, and they just show tons of polys, like this. Abscess. Cellulitis, though, interestingly enough, looks a little bit different. That's more of an interstitial, mostly pattern with neutrophils. That kind of looks almost like neutrophilic urticaria or some of the autoinflammatory diseases. But that's kind of when you see tons of polys, those are really the few things that really cause that. The dense neutrophilic infiltrates, you do think about things like that. Rheumatoid neutrophilic dermatosis can give you dense neutrophilic infiltrate like this. So that's really what you would think about here. And in this case, it turned out, we obviously would work this up to see if there's any infectious component to this, PAS fight, maybe a tissue gram stain or something. All of those were negative. Patient didn't have any, the cultures were negative. This turned out to be an example of necrotizing bullous Sweets disease. There's this new term they're using for necrotizing neutrophilic dermatosis of the hands. Somebody decided to give that a new name, but years ago, we just used to call that bullous Sweets disease. And a lot of those patients that have those horrible types of Sweets disease conditions will have underlying leukemia or lymphoma or something like that. They'll have an underlying neoplasm, often hemologic neoplasm. Now, there are a couple other things too that give you this in this family of neutrophilic dermatoses that you should know about too, other than the things we just mentioned. So there's kind of a tetrad of things that can give you pyoderma gangrenosum, Sweets. There's a couple of other diseases that fall in that category. Anybody know what those are? Kind of big today. It's sort of a new research topic because some of these new biologics are used to treat these things now. So they're now on TV and in magazines. Well, like, hidradenitis suppurativa, folliculitis decalvans, conglomate acne, all those neutrophilic suppurative processes, those kind of fall into the same category of these. So think of the neutrophilic dermatoses as a family of conditions in which neutrophils are the predominating cell in the infiltrate. And the other thing is when you see this kind of inflammatory infiltrate, it can drive your therapy. So if you can exclude the diagnosis of an infection here, you can be thinking in terms of, well, what kind of drugs can be used that are going to target neutrophils? Steroids would probably work for this, right off the bat, but you might want to say, well, yeah, but there's a lot of polys here. Maybe we want to use something like dapsone or colchicine or, infliximab, something like that. We know that some of these drugs now will work for these neutrophilic dermatoses. So if you can't really be absolutely certain of the diagnosis, you can look at the pathology and then say, well, let's try to treat it based on what kind of inflammatory cells in the infiltrate. So that can be helpful to you also. Okay, let's look at this one.
I can try it.
Good.
It looks like it's a punch biopsy. It looks like there's this papillary dermal edema almost. And I noticed that there's a lot of eosinophils in the spongiotic area, like superficially, and I guess I was going along the eosinophilic spongiosis differential. I
Now, is
also
everything here an eosinophil? There are eos, but are they all eosinophils?
there's also some neutrophils.
Neutrophils, yes. And is this papillary dermal edema, or is this maybe even actually a true subepidermal blister that's formed?
Yeah, that's what I guess I was in between. I mean, I think it might be a subepidermal split actually.
Yeah, it's a subepidermal blister. It's a little challenging because I think there is some papillary dermal edema. You're right. There's also some spongiosis, but there actually is a true subepidermal blister that's formed here.
Yeah.
And if you look at this little area right here, this is very helpful finding here. There are polys here and eos, but there are polys. And where am I pointing here?
It's like the papillae.
The tips of a dermal papilla. Good. So does that give you any thoughts here?
I guess like initially with the EOs, I thought of a BP, but then I guess with it's not like dermatitis herpetiformis, right? Or
It's not?
yeah, or I guess it is because it's the tips of the papillae, so that fits.
It actually is dermatitis herpetiformis. This is an example of DH. It's a little confusing in a way because this isn't, if you get a real super early lesion of DH, so let's say we just had something just like over here, we've got some neutrophils at the tips of this dermal papilla, and we don't really have much else going on. This is what you see in a very early urticarial lesion of dermatitis herpetiformis. That's what this looks like. When it becomes really inflamed, it starts looking like this, and eosinophils come into the lesions also. So neutrophils are the first cell that comes in. So you get IgA that's deposited. IgA is chemotactic for neutrophils. The neutrophils come in, they're secondary to the IgA deposits. And then you get a lot of inflammation, and then you start getting spongiosis, you get the blistering, you get eos, you get lymphocytes. You can even get some deeper dermal inflammation like down here. So it can this is sort of a later lesion of DH. So it's a little bit kind of confusing. But if you look at some of these other areas where you see the neutrophils at the tips of the dermal papillae coupled with some of these eosinophils, that's helpful. There's one other clue here, especially if you look over here. It's not really great in this example, but you start getting this so-called basophilia of the papillary dermal collagen. Anytime you get neutrophils in an infiltrate in the papillary dermis, sometimes the collagen bundles will sort of take on this basophilic character, like you see here. It's basically the enzymatic change that occurs with the degranulation of the neutrophils, and it damages the papillary dermal collagen. It gets basophilic. In bullous pemphigoid, theoretically, this could be bullous pemphigoid. I wouldn't say it couldn't. I mean, the other couple of things I throw in the differential diagnosis would be like a bullous arthropod assault reaction could look like this too. There is a dermal involvement here. Pemphigoid usually gives you a band-like infiltrate of lymphocytes and eos, and rarely neutrophils. You sometimes get neutrophils in bullous pemphigoid, but it's relatively rare. And if you get an early lesion, like an urticarial lesion, you'll see a band-like infiltrate, usually not sufficiently deep like this, more of a band-like infiltrate with lymphs and eos. So this one was Dermatitis Herpetiformis. But if you went down that differential diagnosis that you did of eosinophilic spongiosis and whatnot, like allergic contact dermatitis, bullous bug bite reaction, some of those kind of things, that's certainly reasonable. So this is an example of a kind of a florid late stage DH, and this was confirmed with immunofluorescence. So I think it shows that sometimes DH can, look a little bit different. Okay, so you guys did a great job. Your first unknown session, good. So we will do this again next month, and keep up the good work.